Uh, yes, sir, it's moving.
Okay. So, first slide we have already discussed. Actually, there was no any uh, picture. So this is more important, I think. Yeah, this one. Is it clear now?
Yes, sir.
Yeah. So actually, this acute coronary syndrome we can divide into four parts for to differentiate from stable angina, unstable angina, non-STEMI, and STEMI. STEMI is very clear. If you can see that there is the ECG changes and you can easily detect that there is some problem. But for the rest of the things, you have to identify, you have to work a lot from this one. Basic pathophysiology is the same, that there is plaque and there is disturbance in the blood supply of the specific part. But how much of the blood supply is disturbed means how much percentage of the blood supply is not being delivered to the parts of the heart. This is variation among stable angina, unstable angina, and STEMI. STEMI and non-STEMI both are almost similar as per like pathophysiological point of view, but they are not represented on the ECG. That's why non-STEMI, they have to dig it out and they have to diagnose on time so that they can save major event. Rest, stable angina and unstable angina is a little bit different. Like if like stable angina is this one, like you know that after walking so many steps, you will feel the chest pain. And this one, like you already know, because your heart can work maximum up to this limit. But if you are feeling same chest pain with less number of steps, or you are feeling more chest pain with the same number of the step, they will convert into the unstable angina. So these are the ECG. In stable angina, the ECG is normal. On unstable angina, there is sometimes normal, sometimes there is ST inverted, or sometimes depression. And same is the unstable angina, non-STEMI, same ECG is usually there. Then you have to dig out what the actual problem is. So how we will going to manage this condition in acute coronary syndrome? Once the patient comes with any chest pain, so there is first step to obtain 12-lead ECG within 10 minutes, and you have to give aspirin within 10 minutes if the patient is not already taking particularly the loading dose. If from the ECG, if it is clear that there is ST elevation and there are troponin are positive, so the diagnosis is confirmed. You have to go for either fibrinolytic approach or early invasive approach, that you have to do catheterization and or the cabbage, whatever is very clear. You have to do PCI, means for primary PCI is the 90 minutes time. And if the 120 is the maximum limit, if any facility cannot do primary PCI in 90 minutes, means within 120 minutes, then they have to give fibrinolytic therapy like in 30 minutes. Means for PCI, door to balloon time is 90 minutes, and for fibrinolytic therapy, door to needle time is 30 minutes. So after this, there is the post procedure therapy you have to begin. For on the other side, the things are pretty complicated. Yeah. You have to diagnose whether there is unstable angina or NSTEMI. If the troponin are positive, then the diagnosis is pretty much that NSTEMI, non-ST elevation myocardial infarction. And if the troponin is negative, you can say that this is the unstable angina. Again, you will perform risk stratification and multi-lead continuous monitoring of ECG. Then you have to obtain serial of troponin, because troponin are maximum after the event. Sometimes the patient is has event like 2 days before or 1 day before, then the troponin declines. There is another CKMB test which they perform to know whether the event has occurred or not. Sometimes the patients are getting multiple events like multiple myocardial infarctions, though they can monitor from the troponin. So then they have to stratify that whether the patient is high moderate risk and high risk. Then they will go further for risk stratification. If the patient is with moderate and high risk, then they have to again go for the early invasive approach. And if the patient gets fine after some time, then it means that there is no chest pain after some time. The patient they consider as a low risk, they will also study the ECG. Then for the moderate, this early invasive approach will also go to PCI or CABG, whichever
Dr.
the approach.
Bilal,
Yes, yes.
sir, on which slide you are? You are on pathophysiology still?
No, it's already third slide. It's not moving again.
Yeah, so you are. We are sure it's just clear pathophysiology, acute coronary stable angina, unstable
No, I am
hypertension.
already on 7th slide almost. I will
Okay,
just
doctor, can you leave and you can join again? Might be it will work.
yeah, I will leave it again. I'll leave and join again. Yeah, sure.
Okay, okay.
Okay.
Participant, please wait for 2 minutes.
Okay.
Okay, Dr. Bilal, can you please change your screen? Yes, it's working now. That's it.
Doctor, can you unmute your mic? We can't hear you.
So it's okay now?
Yes, sir. Oh, it's
Yes,
working.
doctor.
Okay. So for this, I will just try to explain the first slide again, that because there was no coordination, it's very necessary to understand this part. The patient comes with chest pain after 12 lead ECG, and you have to give aspirin at the moment within the 10 minutes. That there are two options, whether it's ST segment elevation or there is a depression or no changes. If it is elevation, the path is very clear. The patient have had myocardial infarction if the enzymes are positive also. So they have to perform primary PCI within the 90 minutes, and if in the 120 minutes, the maximum time they cannot perform, they have to give fibrinolytic therapy within the 30 minutes. And then they have to take care of the patient after this procedure. So this STEMI path is very clear. On the other side, the path is not very clear. That first they will check the troponin enzyme, and if the troponin is positive, then it becomes pretty clear that this patient has MI. So then they will evaluate the risk, whether this patient is moderate to high risk or low risk. If it is a moderate to high risk, they will again go for the early invasive approach. They will do the catheterization. But if the troponin is negative, they will do further studies to find out what's the reason. If it's in the unstable angina, if it is like low risk, then they can go for a ischemia guided approach. They will give the medication and they will perform the stress test in unstable angina. If even if the troponin is positive and the patient is not feeling any symptom, again the patient is coming in the low risk, then they will again perform stress test. So sometimes there is short time blockage in the artery and it opens again, the troponin gets high. So they will perform different further diagnosis. And if the stress test they will perform, they will make the heart to work more. There are like two parts of the heart, like it's basically one is the healthy heart, the other one is the dead heart. They have to find out the part of the heart which is at risk. So at risk part is doing well at the rest, but when heart is made to work more, then it becomes stunt. That part they have to diagnose, where the blood is not getting enough, heart is not getting enough blood supply. So when they will perform the stress test, they will find out the part of the heart where which cannot work when there is more severe conditions. So if they find such kind of the part of the heart, it means that this part of the heart is not getting 100% blood supply. They will catheterize, perform angiography. They will see how much percentage of the artery supplying the oxygen and food supply, means blood, to this part of the heart. And if it is like 90% blockage, they will have to perform PCI again or cabbage, but depending upon the condition. And if it is a less, then they will decide that whether they have to go for a ischemia guided approach for the long time. So decision for invasive management, STEMI. Primary PCI is preferred to lytic therapy. Primary PCI within the 90 minutes. First medical contact. Fibrinolytic therapy is indicated for patient with STEMI. In-home PCI cannot be done within the 120 minutes. Performance measure for lytic administration include auto needed time 30 minutes, because in 30 minutes, then you have to give the fibrinolytic therapy so that you can dissolve the clot and you can open the coronary artery. Non-ST elevation acute coronary syndrome are treated on the basis of risk teaming race with either early invasive strategy or ischemia guided strategy. So this is teaming race. There are some score, you have to, there are different factors, you have to score them. And based on this score, you will calculate the risk. If it is a high risk, then you will go for early invasive strategy. If it is a low risk, then you will go for a ischemia guided strategy. Initial treatment, both for the same. It's monab like morphine, oxygen, nitrogen, aspirin, and beta blockers. So morphine basically is an analgesic effect and decrease pain-induced sympathetic adrenergic tone. Oxygen can help attenuate anginal pain, secondary to tissue hypoxia. Nitroglycerin facilitate coronary vasodilation and may also be helpful in severe cardiogenic pulmonary edema caused by venous capacitance. Aspirin inhibits platelet activation. Beta blocker decrease myocardial ischemia, reinfarction, and frequency of dysarrhythmia. So, antiplatelet and anticoagulant therapy. Basically, they have to stop both primary hemostasis and secondary hemostasis. By giving antiplatelet therapy, they will give the primary hemostasis. They will choose two of them, aspirin and P2Y12 inhibitor or intravenous G2B3A inhibitor. For anticoagulant recommendation for STEMI, there are only two options when they are performing primary percutaneous coronary intervention. Unfraction heparin or bilirubin. So they will not give enoxaparin or fendaparinox. For STEMI with fibrinolytic therapy, there is option for enoxaparin and fondaparinux. For non-STEMI STLV ACS, enoxaparin, bilirubin, unfraction heparin, and non-STEMI ACS ischemia guided strategy, enoxaparin, fondaparinux, unfraction heparin. They have to choose both classes, dual antiplatelet therapy and anticoagulant. 2 from the antiplatelet and 1 any of from this section. So there is a case about this a 62-year-old man presents to the emergency department with the chief concern of chest pain that woke him from the sleep, radiates to his jaw. An electrocardiogram ECG revealed ST segment depression in lead 2-3 and AVF. His blood pressure is 112 62 millimeter over 62 millimeter mercury, and heart rate is 60 beats per minute. Cardiac enzymes have obtained, and the first troponin result was slightly positive. Preparations are underway to take the patient to the cardiac catheterization laboratory for evaluation, which medication regimen is the most appropriate for this patient. So blood pressure is 112 over 62 millimeter mercury, heart rate is 60 beats per minute. This is the major concern, and 62-year-old and troponin are positive. So if troponin is positive and ST segment depression, this one, it's already 62 years old. So the patient, they will go for catheterization. You have to choose for now dual antiplatelet therapy and heparin or bilirubin. From which one you will choose? Aspirin 325 milligram. This one is a correct dose because they have not given any medication list for the patient what he is taking. So aspirin loading dose we will give is 325 milligram. So there are 2 options with 325. 81 milligram we will just roll out because this is not the recommended therapy. From A and C, we have to choose which one is the next. Clopidogrel 600 milligram, this is correct. Loading dose with unfraction heparin 80 units per kg, followed by the 18 units per kg per hour, metoprolol 5 milligram intravenously. Here are 2 points are not correct. That at this point, we will not give metoprolol, although we will start metoprolol like in that 24 hours. But at this time, when its heartbeat is already 60 beats per minute, we can roll out this metoprolol also. If we will give, this one can go in cardiac shock. And blood pressure is already low, 112 or 62 millimeter mercury. So this option is also ruled out. Then there is the third option, C, the aspirin 325 milligram, ticagrelor 80 milligram. Loading dose unfraction heparin 60 units per kg bolus and followed by 12 units per kg per hour is according to the guidelines. So fibrinolytic therapy, when the PCI is not possible within 120 minutes, then in the 30 minutes you have to give fibrinolytic therapy. There are altiplase, retiplase, and tenecteplase. Mostly we are using altiplase. In altiplase, we have 50 milligram 1 vial. There are usually 2 vials for 1 dose because 100 milligram is the maximum dose. So this is the dose, like if 67 kg below weight, 15 milligram IV push over 1 to 2 minutes, then 0.75 milligram per kg IV over 30 minutes, then 0.5 milligram per kg over 60 minutes. This is the fibrinolytic therapy. Retiplase and tenecteplase, usually we don't have over here, but its dose is 10 units IV push repeats, 10 units IV in 30 minutes. Tenecteplase less than 60 kg, 30 milligram IV push 60 to 69, 35 milligram per kg. So this is the dosage for tenecteplase. So this usually this one case I remember it came in our time, so that's why I put this one in my presentation. A 45-year-old patient underwent an elective percutaneous transluminal coronary angioplasty. A drug-eluting stent placement in her right coronary artery, which best represents the minimum time for DAPT should be continued. For ACS, there is standard guideline that for 12 months you have to continue the dual antiplatelet therapy. But this patient underwent an elective percutaneous. This is not due to the ACS. So whenever there is for elective percutaneous transluminal angiography and the stent is drug-eluting stent, there is another one bare metal stent. For bare metal stent, you can use the dual antiplatelet therapy for 1 month, but for drug-eluting stent, there should be minimum 6-month antiplatelet therapy. You have to. So its correct answer is C, 6-month antiplatelet therapy. Long-term management after ACS, you have to give DAPT, beta blocker, aldosterone receptor blocker, lipid-lowering therapies, pain control, vaccination, patient education, cardiac rehabilitation. About these factors, you have to give after ACS means once a patient is diagnosed with ACS, acute coronary syndrome, these are therapies you have to continue and you have to keep monitoring the patient. Next topic is acute decompensated heart failure. So this topic we have already discussed, more or less similar to this topic, congestive heart failure. Congestive heart failure and decompensated heart failure are a little bit similar, but this one is an acute condition, a sudden worsening of signs and symptoms of heart failure, which typically includes difficulty in breathing, leg, feet swelling, and fatigue. So we have already discussed, I will just explain again a little bit about the heart failure situation, that heart is basically pumping the blood through the vessels of the body, and vessels are responding according to the heart. Sometimes if cardiac output drops, vessels get congested. There is vasoconstriction in the vessel to compensate the fluid, which is the heart is not giving them proper, which is less, and they will get strict. So if the normal heart is playing okay, so the behavior is also okay. So we will just discuss in detail. Diagnosis must include detailed history, physical examination, B-type natriuretic peptides, BNP, and anti-pro-BNP is useful to support the diagnosis. These are some peptides released when there is extra pressure on the valves of the heart, and they will do as a protecting work, like they dilate the blood vessel so that there should be support to the heart. Hemodynamic monitoring with pulmonary artery catheter helps in evaluating patient refractory to initial therapy, patient with unknown or unclear volume status, the patient with clinical significance, hypotension, worsening renal function. There is pulmonary catheter, they place just before when the artery exits from the heart and it's going to the lungs, they place at this point one catheter. The pressure they measure from this catheter to pulmonary capillary wedge pressure, also they call this one. This is very important. They will tell us about how much pressure is over there. This pressure measures two things. One is the volume status, how much volume is in the body, and if it is volume is piled up in the lungs, it will also increase. The other thing is this one, if the peripheral vasoconstriction is there, this volume, this pressure will also get high. So we will just discuss these things in detail. These are some hemodynamic values. Like we discuss also some of these in congestive heart failure. Mean arterial pressure. In the ICU patients, mostly we are dealing with the mean arterial map, not like systolic blood pressure and diastolic blood pressure. Most of the time our target is above 65, because 65 is arterial pressure at which your body organs are perfused, means well perfused. If the blood pressure drops below this, the body organs are not perfused and they can deteriorate in their health, like they will not work properly, your kidneys, liver, vital organ like CNS. So heart rate, here there are different values, like normal value, mean arterial pressure is 80 to 100. Typical in acute decompensated heart failure is 60 to 80, and typical sepsis 60 to 80. These are some values. Heart rate, 60 to 80, normal, typical ADHF 70 to 90, and typical sepsis 90 to 100. Cardiac output in liter per minute, 4 to 7 liter is normal. In typical decompensated heart failure, it is 2 to 4 liter. The volume has dropped over here, and typical sepsis 5 to 8 liters. Cardiac index, we will divide this cardiac output by the meter square body surface area. So it will be 2.8 in normal to 3.6, 1.3 to 2, and typical sepsis 3.5. Pulmonary capillary wedge pressure, this is another important thing where we will measure the volume status of the body and the overall pressure in the vessels. It's 8 to 12 is the normal, 18 to 30 when this decompensated heart failure, and typical sepsis, it drops to 5 to 8 because in sepsis there is no more resistance in your vessels and they are dilated. So the pressure drops in this pulmonary capillary wedge pressure. Systemic vascular resistance, normal 900 to 1400, 1500 to 3000 in ADHS. Sepsis, as I told you that this one drops, the resistance drops, that's why the pressure will also drop 300 to 800 only dynes per second per centimeter square. Central venous pressure 2 to 6, normal 6 to 15, 2 to 6 again in sepsis. So these are some formulas you can calculate these values from these formulas. So there is a clinical case, a 62 years old man presents to ED after several hours of chest discomfort. His ECG reveals 1 to 3 millimeters ST segment elevation with positive troponin. He also had increased shortness of breath, lower extremity swelling over the past 2 to 3 weeks. His medical history significant for tobacco use, 40 years, chronic obstructive pulmonary disease, diabetes, hypertension. His blood pressure is 102 over 76 millimeter mercury. Heart rate is 111 beats per minute. He has rales in both lungs and 2 to 3 pitting edema. Extremities, his echocardiogram reveals an ejection fraction is 25% only. After primary percutaneous coronary intervention, he's transferred to the cardiac intensive care unit, which is the best acute use of beta blocker therapy in this patient. So beta blockers, how we will judge this patient? Like beta blocker will affect on the heart. Okay, effect on the heart will reduce the work of the heart basically. So if we will see that if what's the works of the heart is ejection fraction is only 25% already. And the pitting edema means due to this, whenever there is failure of the heart, the pump breaks down. Means that the volume will also accumulate in the arteries, it will not circulate, and it will also accumulate in the lungs. If you will see that there is already volume accumulation in the pulmonary part where there is a rales, you are feeling when you are breathing, you can see that there is shortness of breath. It's due to the accumulation of volume in the lungs, and the other pitting edema in the extremities also then means that the heart is not working properly. And if you will give any beta blocker at this time, when they have already performed, they will make the worse cardiac function. Means any kind of like 12.5 milligram is really high dose. No doubt you have to start after 24 hours some beta blocker, but not from this dose like 12.5 of carvedilol, 5 milligram of IV 10 times more potent as oral. So like 50 milligram of oral metoprolol. For these patients, whenever they come, you have to titrate, particularly in the old age people with the heart failure. Like you will start with 2.5 milligrams sometime of carvedilol like this after 24 hours. But at this time, they have just performed the PCI. So at this time there is no need for beta blocker, particularly at this time. So clinical presentation of acute decompensated heart failure. Basically, this patient is of heart failure patient. So we can be categorized into 4 subsets of basis of fluid status, cardiac function. In acute decompensated heart failure, we just divide the patient in 4 things. wet or dry is from the volume status. If the volume is too much in the body, the patient will be the wet. Or dry, if the volume is euvolemic or less volume, the patient will be the dry. So this wet and dry, you will calculate from the pulmonary capillary wedge pressure. If the wedge pressure is too much, it means that the patient is wet and there is too much volume in the body. And if the pulmonary capillary wedge pressure is less, so it means the patient is dry, and how much dry you can calculate from the pulmonary capillary wedge pressure. The other condition is warm or cold. If the patient is warm, it means that the patient is okay. Warm means that circulation of the blood. If we touch the shins or ankles of the patient, so if you can feel the temperature of the body temperature correct, it means that there is a circulation, enough circulation to keep the parts of the body warm. If there is any like less, actually, if the heart is not performing well, he is not pumping out enough blood. So peripheral, there is peripheral vasoconstriction. The response to this phenomenon of the heart is due to that they should supply maximum blood to the visceral parts, means that the vital part of the body, like brain to kidney to like liver. So peripheries get vasoconstriction and your peripheries get cold. So that's why they are used to describe the cardiac function and the ability to perfuse the tissue. Congestive, there are two things. In hypoperfusion, there is low cardiac output, and in congestion, elevated PCWP. I mean, when there is too much fluid in the blood body, the PCW, pulmonary capillary wedge pressure, will increase. If it is hypoperfusion, there will be due to the low cardiac output. What are the symptoms of elevated PCWP? Because these things I'm discussing in detail, because in the case you will evaluate from these things. If you understand them well, you can understand the case easily, that where the problem is, and then you can resolve the problem. Congestion, dyspnea, exertion, or at rest. That means you are not able to breathe because the fluid will accumulate in your lungs. You will feel exertion at rest or when you will perform some work. Orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, rales, early satiety, nausea, vomiting. Basically, your visceral parts are also getting supply from the cardiac output. If there is too much already volume and they are not getting fresh supply of the blood and it's not circulated, you will not feel hungry, they will not perform well. Ascites, fluid can accumulate in the belly, hepatomegaly, splenomegaly, jugular vein distension, hepatojugular reflex. These all are due to the congestion, due to the extra volume in the blood, in the body. The hypoperfusion, fatigue, altered mental status, sleepiness, cold extremities, worsening renal function, narrow pulse pressure, particularly this narrow pulse pressure representing that hypoperfusion, low cardiac output, means sometimes when the cardiac is not pumping enough blood to perfuse your body, your peripheral vessels get constricted and they are not even dilating when there is a diastolic blood pressure. You will see that 110 is the systolic blood pressure and 100 is the diastolic blood pressure. Means that they are not relaxing anymore to supply maximum blood to vital organs. Hyponatremia, these all are hypoperfusion symptoms. Foster hemodynamic subset, basically this is pretty complicated. From these two indications, one on x-axis is pulmonary capillary wedge pressure, and from cardiac index output means cardiac, how the cardiac is working, and how much is the blood volume in giving the pressure on the pulmonary capillary wedge pressure. So basically this pulmonary capillary wedge pressure representing not only the volume, but also like how much pressure facing from the vessels. If there is vasoconstriction, the pulmonary capillary wedge pressure will also go high. So basically the normal box is this box, warm and dry. This is the normal category 1. For this one, cardiac index should be from 2.2 almost to 4 like, and pulmonary capillary wedge pressure should be from 8 to like 16. So this is the ideal box from which the body should maintain the heart. So if we go from here to here in category 2, pulmonary congestion, warm and wet, if the volume get accumulated in the body and the body will be wet and pulmonary capillary wedge pressure will be increased from 18 to like 25. So if you want to bring from this category to this category, the solution is simple, that there is congestion. The wet means volume is more. You will give diuretics. The patient can come in this category. Again, from here, there is again one problem, only hypoperfusion. The heart is not able to perform enough work and the cardiac output is less than 2.2. You have to increase the work of the heart and you can take this hypoperfusion to this one, to this category. The patient is cold and dry. Means the patient is euvolemic, but it's cold due to the poor performance of the heart. This work, category 4, is the most complicated category. Means in this, there are both problems. Heart is also not performing well, and the body has enough volume. Body has more volume than the needed, and sometimes there is more resistance from the peripheries. When the heart is not performing well, you have to evaluate wisely that whether this problem is pulmonary capillary wedge pressure is because of cardiac index, or this one is due to the extra volume in the blood. So once you have understood this one very well, then you can solve these cases. So therapeutic management, how you will manage this, like first warm and dry. So in warm and dry, this case, optimized guided rectal medical therapy is PO medication. This one is the like normal box, warm and dry. PCWP 15 to 18 millimeter mercury is normal. Cardiac index is greater than 2.2 liter per minute. Subset 2 is warm and wet, pulmonary or peripheral congestion. PCWP, whenever there is wet, pulmonary capillary wedge pressure will go beyond 18 millimeter mercury. Cardiac index will be the same again, greater than 2.2. So you have to just remove the extra volume. You will give IV diuretics dose equal to or exceed the pre-admission dose up to 2.5 folds. You can give like, if the patient is taking like 40 milligram, you can give 100 milligram of furosemide. IV vasodilator you can give, because if there is pulmonary peripheral congestion, for rapid relief of pulmonary congestion. Like if you will give vasodilator, the fluid will move from lungs to the periphery so that the patient will be able to breathe. If you will see that the patient lungs are more congested. If symptoms persist, preventive strategies to overcome the diuretic resistance may be the necessary. Subset 3, cold and dry, hypoperfusion plus minus orthostasis. PCWP is 15 to 18. This one is normal, but cardiac index is less than 2.2 liter. Now here you have to evaluate patient very carefully, because in subset 3, if PCWP, pulmonary capillary wedge pressure, is less than 15 millimeter mercury, so it means that the patient does not have enough volume in the blood. You will have to give the volume, because the normal PCWP should be the greater than 18 millimeter mercury or greater than 15 at least. So you will give volume until the PCWP is from 15 to 18. The next, if PCWP is greater than or equal to 15 millimeter mercury and systolic blood pressure is less than 90 millimeter mercury, you have to give the inotropes. It means that the volume is good in the body, but from the systolic blood pressure, you will see that it's 90 millimeter mercury. Its heart is not working well, so you will support the heart from the inotropes. On the other side, if PCWP, pulmonary capillary wedge pressure, is greater than 15 millimeter mercury, it will again tell us that the volume is good in the body, and the systolic blood pressure is greater than 90 millimeter of mercury, you will give the vasodilator. You have to distribute properly the blood or volume in the body. This one is the most complicated, cold and wet, pulmonary capillary congestion, hypoperfusion, PCW usually greater than 18, cardiac index is less than 2.2. First, you will give the IV diuretics. Usually, so sometimes they suggest that to give the vasodilator so that you will get the idea of where is the problem, because the problem can be on both sides, whether the fluid is more or the cardiac index is less. Once you have distributed the fluid in the body correctly, then you can give the diuretics to fix and the vasodilator accordingly. The situation, if systolic blood pressure is greater than 90 millimeter mercury, you will give IV vasodilator, and if it is less than, you will give inotropes, then vasopressor if they are needed. So 60 years old woman with New York Heart Association class 4 heart failure with reduced ejection fraction is admitted for increased shortness of breath and dyspnea of address. Her extremities appear well perfused, but she has 3+ beating edema in her lower extremities. Her vital signs include blood pressure 125/70, heart rate 92 beats per minute, oxygen saturation 99, 100% face mask. After initiating intravenous diuretic, which intravenous agent is the best rapidly treat this patient's pulmonary symptoms? So this patient is already in class 4. Heart failure means heart output, heart ejection fraction is already very less if it is in class 4. And edema is there due to the heart failure. Blood pressure sign is like 125/70 is less. Heart rate is 92 beats per minute. It's almost high, and saturation is good. How you can reduce his pulmonary symptoms? Dobutamine will support the heart, but will not remove the pulmonary symptom. Milrinone will also. Nitroglycerin will dilate the blood vessels and will switch the volume from lungs to the peripheries. And metoprolol is the beta blocker. If we'll give this one, it's already in like class 4. So the correct answer should be the nitroglycerin, so that it will dilate the blood vessels and will switch the volume. This is basically coming in warm and wet warm and wet category, because this one is well perfused, is warm, and it has over more than the required volume is wet. So after giving IV diuretics, you have to give vasodilator for rapid relief of pulmonary congestion. So once you have identified, because where is the problem, then you can go and fix the problem. So acute, here is arrhythmias. This actually a topic is also very long. So I will discuss this one shortly, because arrhythmia is like the heart is not in the rhythm. If the heart is not in the rhythm, again, it will not be able to perform its work, and there will be compromised blood supply to particularly like the CNS, and the patient gets fainted. Therefore, once the patient is in syncope, usually, so there is mostly cardiac arrest. The patient is not able to pump enough blood to perfuse the organs. So there are basic life support and advanced cardiac life support. There are two courses usually. Here we all healthcare workers are are doing this basic life support, that if the patient gets in cardiac arrest, you have to start, you analyze what's the problem. If the patient is not responding, you will start chest compressions, and you will just give breathe. If there is external defibrillated device, you will put this one and you will shock the patient, because sometimes there is cardiac arrest due to this arrhythmia, and the patient will get back. So this is whole therapy is after this adult cardiac arrest. Once the patient is in arrest, cardiac arrest, and there is advanced cardiac life support, they will shock, and they will give some medication. This is whole process. There is a long table. Then when you will start CPR, there is a rhythm. You will analyze that. Machine will analyze whether this is shockable or non-shockable. Then defibrillation, you will shock the patient. You will perform CPR like 2 minutes. You will establish IV access line during this time. And if the patient comes back, this is whole process, that if the patient does not come back, you will again perform CPR. You will give epinephrine, and you will give amiodarone. During this whole, there is a specific steps you have to follow. Once the patient gets back, then you have to go through these steps: targeted temperature management for cardiac arrest, that's symptomatic. This is like not very complex, but you have to memorize these steps. That's why I have not written the detail of them. After getting back, sometimes the patient have symptomatic bradycardia, tachycardia. You have to treat them long-term management of ventricular arrhythmias, and non-sustained ventricular tachycardia, asymptomatic, symptomatic, and symptomatic tachycardia is particularly symptomatic bradycardia, usually treated with atropine. If atropine fails, then you can go for dopamine or epinephrine. And symptomatic, mostly tachycardia, if it's unstable, you have to synchronize cardiovarian. You have to perform like cardiac shocks with electric shock. And if stable, then you will study further. You will study QRS complex, whether it's narrow and or irregular narrow complex. You will study this cardiovarian, you will perform. So it's like in the end, there is a solution. If it is not able to implantable cardioverter defibrillator, sometimes they are called pacemakers also. They also come in this category. You will put these for to treat this arrhythmias. So there is antiarrhythmic drug. Basically, heart has specific cycle like polarization, depolarization, repolarization. So these drugs are acting on specific part. So there are three, the 4 classes: class 1, PharM 1B, 1C, 1A, 1B, 1C. Class 2, there are the beta blockers. Class 3, calcium channel blocker. Class 4, calcium channel blockers. So we don't have much time to discuss in detail this thing, but I think you will just study and you can understand it well. It's not very complicated for arrhythmia, because we have studied in our during the college also. So there is more like medical condition which are coming in this exam, are hypertensive crisis. There are 2 kinds of hypertensive crisis: hypertensive emergency and hypertensive urgency. In emergency, usually your blood pressure is greater than 180 over 120 with evidence of new or worsening target organ damage. Means there can be MI, there could be hemorrhage, there can be kidney failure, there could be retinal damage. These events can happen above this blood pressure, particularly like those in those patients, those before there was no any hypertension, and they're not used to of this high blood pressure. Requires immediate blood pressure rolling, not necessary to the normal ranges, to prevent limit further target organ damage. Usually they have to reduce like 25% first, and then they have to make normalize in 24 hours. In hypertensive urgency situation associated with severe blood pressure, So, in other words, stable patient with acute or impending changes in target organ damage or dysfunction. Short-term risk is not as high, therefore blood pressure reduction occurs over several days, not immediately. Hypertensive emergency, the goal is to minimize target organ damage safely by rapid recognition of problem and early initiation of appropriate antihypertensive treatment. Patients are usually admitted for intensive care unit and close follow-up, lower MAP by no more than 25% in first hour. Then reduce systolic blood pressure to 160 millimeter mercury and diastolic blood pressure to 100 to 110 millimeter mercury over next 2 to 6 hours, then to normal over 24 to 48 hours. Hypertensive urgency treated in reinstitution of intensification of antihypertensive drug therapy, no indication for referral to ED, immediate reduction in blood pressure in ED or hospitalization. So hypertensive emergency treatment, usually we give vasodilator and beta blockers and adrenergic inhibitors. So usually there is the rule that if heart rate is above 90, you will give beta blockers, and if it is below 90, you can give vasodilator. It's a general rule, because if it is above 90 and you will give the vasodilator, there will reflex tachycardia and heartbeat will increase. If it is greater than 90, the beta blockers will support in both ways. Here's a clinical case of 56-year-old white woman with long history of hypertension because of non-adherence and recently diagnosed heart failure. 35% present to the local ED with blood pressure 210 over 120 millimeter mercury. Heart rate is 105 beats per minute. She states that she felt little lightheadedness. Now this is the condition that you have to observe, that although the blood pressure is really high, but how she is feeling, is there any damage, is there, she's feeling like, is there any event like myocardial infarction, chest pain, or like symptoms of hemorrhage. She says that she felt little lightheaded, but that she's no feel okay. I mean, she's still okay, there is no any damage. She ran out of her blood pressure medication, including hydrochlorothiazide, carvedilol, and lisinopril 3 days ago. 3 days she is not taking her medication. Her current laboratory values are within the normal limits. Which medication is best for the patient? Sodium nitroprusside. If you will see that the heart rate is 105 beats per minute, sodium nitroprusside you will not give. Labetalol 80 milligram intravenous regulate blood pressure. This can be the choice, but whether we need for this patient or no. Resumption of home medication, refer for follow-up within the 2 days. Resumption of home medication, initial amlodipine 10 milligram daily, refer for follow-up for 1 week. For in this condition, if the patient was already stable for some medication, and if you will see that with long history of hypertension, means that the patient was already stable on some medication. He has history of hypertension, and but due to the non-adherence, the blood pressure, the reading is 210 over 120. So this is the most suitable answer. Resumption of the home medication, referred for follow-up within 2 days. Because if the blood pressure is too much high, you cannot ask that come after 7 days, particularly when the patient has gone to up till this blood pressure 210 over 120. So this is the most suitable answer. You will not initiate any new medication unless you will not give the current medication, and you will reevaluate whether these medications are working properly or not. If after starting this medication, if the patient is not feeling well and the blood pressure is still high, then you can go up to this step that you can start any other medication. I hope this is the end. So in this way, I have completed my session. If there is any question, so you can ask from the chat.
Thank you so much, Dr. Bilal, for the amazing presentation and the cases. I can't see any questions in my chat. Maybe do you have it in your chat?
Yeah, no, there is
or you
no
can just open your mic if you have questions.
Yeah, okay. Anyone who wants to ask anything, you're most welcome.